Hello, my name is Amy Werremeyer, and I'm here to present to you about our project, the evaluation of the impact of a methadone medication dispensing unit in a North Dakota community pharmacy. I'm a member of the One Program team, which stands for Opioid and Naloxone Education, and this program is housed in the Department of Pharmacy Practice at North Dakota State University. And numerous collaborators have contributed to the success of this work and to the development of the project I'm about to talk to you about today. And a little bit about the background. So it's probably not a surprise to many of you that opioid overdose deaths and opioid use disorder diagnoses continue in the United States. We have heard recent reports that the number of overdose deaths has gone down, but there's still some caution about interpreting that information and some caution about how far across the United States that kind of statistic actually applies. In some pockets, we're seeing, especially in rural areas, there actually are increases in overdose deaths. North Dakota hasn't seen a recent increase in overdose deaths related to opioids, but the leveling off of our overdose death rate is not maybe as pronounced as is being seen in other country or other areas of the country. For example, in North Dakota, there were 127 overdose death cases in 2023, and then 118 in 2024. So, how do we go about addressing this? Well, methadone is one of the most reliable ways to treat opioid use disorder and prevent opioid related fatality. It is the gold standard for treating opioid use disorder. Federal regulations, though, really limit the availability and accessibility of methadone. The regulations require that methadone for opioid use disorder treatment be dispensed only from licensed opioid treatment programs, or OTPs. And North Dakota has just 4 licensed opioid treatment programs, and all of these are in urban areas in North Dakota. And that means that our rural patients that are enrolled in methadone treatment often face long daily driving distances in order to obtain their treatment. In the early stages of treatment with methadone, it is required by the federal regulations that methadone be picked up from the opioid treatment facility every day. Um, in one North Dakota county alone, there are more than 20 patients who reside there who are driving more than 140 miles round trip to obtain their methadone each day. So the dark purple boxes in the left-hand picture of North Dakota are where our methadone opioid treatment facilities currently are, licensed opioid treatment facilities. And as I've mentioned, long driving distance is a well-established barrier to continuation of methadone treatment. The right-hand picture with the various colors of oranges and whites in the North Dakota counties show the driving distance to obtain any medication for opioid use disorder, not just methadone. Um, so we know that there are places in North Dakota that have even further driving distances than the ones I quoted to you. This is one-way driving distance to obtain any medication for opioid use disorder. So in North Dakota, we really have a need for increasing access to this effective treatment. And one of the additional reasons why is that we know premature methadone discontinuation is associated with 3 times greater mortality than when it's continued long term. So this project is going to try to address that in some way. We do know that the federal regulations allow for opioid treatment programs to establish what are called medication dispensing units, or MDUs. And this is, you might think, is this like a vending machine, or what kind of apparatus is this medication dispensing unit? And that terminology can be a little bit misleading because it's not actually an automated medication dispensing unit in any way. It's not automated. It's not a vending machine. It's actually just a facility that is in a contractual relationship with the opioid treatment facility to provide methadone and make it more available in places where people may be less likely to be able to get to the opioid treatment facility kind of parent establishment. And so the goal of medication dispensing units is to provide methadone to vulnerable and rural populations. However, not a single medication dispensing unit has been established in North Dakota. That doesn't mean there haven't been attempts, but there haven't been highly coordinated or any successful attempts. Further, a community pharmacy is not one of the places that a medication dispensing unit has ever been tried to be established in North Dakota, but there are some illustrations of that being successful in other places in ways that are at least analogous to what we aim to do in this project. So the regulations do allow that a community pharmacy is one place that a medication dispensing unit can be established. And pilot studies of medication dispensing units in community pharmacies have suggested that patients have a higher rate of retention in methadone treatment compared with when they get their treatment only from the parent OTP facility. And they also have higher rates of satisfaction and lower rates of illicit substance use compared with when they're getting their methadone from the OTP itself. However, these studies have all been conducted in urban areas. They have employed very strict patient inclusion criteria and had very small sample sizes. Further, they largely utilized a model in which primary care providers prescribed and managed the methadone under special licensing exemptions or permissions, rather than working directly with an opioid treatment facility. Thus, there's little ability to extrapolate the results from those prior studies to rural North Dakota and other rural areas. So we aim to, in partnership with Community Medical Services, which is one of the licensed opioid treatment programs in North Dakota, we aim to establish a medication dispensing unit in a community pharmacy and assess the impact. So that is indeed our goal, to evaluate the impact of a medication dispensing unit in a North Dakota rural pharmacy on patient access to methadone. We will do this through two different specific aims. The first is to evaluate the impact of the implementation of a methadone dispensing unit at a North Dakota pharmacy on patient retention in methadone treatment programs. Our hypothesis is that patient retention will be increased because patients will be able to obtain their methadone treatment from the pharmacy medication dispensing unit, which will be geographically closer to where they reside. We will compare the missed methadone doses per 30-day period at baseline and every 30 days thereafter for all patients utilizing the medication dispensing unit, and a cohort comparison of the number of patients meeting criteria for treatment continuance at every 30 days, or TC30, which is an established measure that is common across opioid treatment programs licensed in the United States. So we'll do that cohort comparison at baseline and at 90 days after the medication dispensing unit is established. And through the accomplishment of this specific aim, we will have enhanced our knowledge of having access to a pharmacy medication dispensing unit within closer proximity to patients' residence and how that impacts their retention to treatment programs. The results from this aim will establish the impact of pharmacy medication dispensing units on patient outcomes. The second specific aim will be to examine pharmacy and OTP staff perspectives on medication dispensing unit implementation and operation to help inform hopeful future MDU expansion. So our hypothesis is that the pharmacy and OTP staff perspectives will enhance implementation and expansion in future locations. We will assess this by providing a 90-day post-implementation survey of all staff of the OTP and the pharmacy who worked with the MDU since its establishment. Upon completion of this aim, we will have action steps to improve implementation and expansion of pharmacy MDUs in other locations in North Dakota and perhaps across the country as well. So by implementing a medication dispensing unit in a community pharmacy, and choosing counties that have either the most number of people who are driving a long distance to get to methadone, or that have the longest driving distance to get to methadone, as you can see in the two counties in the circle. Those are the two potential counties we'll be working with in this project. Our inclusion criteria as we approach AIM 1 and assess patient-level outcomes will be current patients of the Community Medical Services opioid treatment program who reside closer to the medication dispensing unit in one of those two counties in the blue circle, which are Mound Trail, the orange county, or Williams County, the darker red. So the patients who live closer to the medication dispensing unit in one of these counties compared to the opioid treatment program that's in Minot, North Dakota, those patients will be recruited to participate. These patients will be offered the opportunity to obtain their daily or otherwise scheduled per CMS protocol methadone doses from the community pharmacy medication dispensing unit in the county, pictured in the circle, rather than traveling to the opioid treatment program all the way in Minot to obtain their methadone. Driving distance to obtain methadone treatment at baseline will reflect the patient's current distance from their home to Minot, North Dakota, while driving distance at 30, 60, and 90 days will reflect the distance from their home to the medication dispensing unit, and this distance is likely to be shorter since the medication dispensing unit is likely to be closer to their home than Minot is. Driving distance will be collected each month, as it is possible that some participants may be unstably housed or have changing life circumstances, such that a monthly examination of driving distance to obtain their treatment may be important to understand the overall trend. It is expected that 20 to 25 patients will be eligible and offered study participation. CMS's study investigator will record data pertaining to AIM-1, including the driving distance to obtain methadone on day 0, missed methadone doses per 30 days, and current TC or treatment continuance 30 status at the time of enrollment as baseline measures, which will be indicated as day 0. The TC30 is defined as receiving at least 75% of methadone doses and at least 1 dose in the last week. These data are already collected by CMS staff and recorded in their medical record system as standard procedure for each of their patients. All data pertaining to AIM-1 will be reported to the North Dakota State University investigators in de-identified fashion. AIM-2 will be an implementation-related outcome, as I've previously mentioned. And this will be conducted by, or will be carried out by utilization of a survey that will be administered at 90 days. And this survey instrument will be administered to all opioid treatment program and pharmacy staff to obtain their perceptions about the implementation and operation of the medication dispensing unit. The survey will include 3 independent measures that have been previously established for the purpose of monitoring and evaluating the success of implementation efforts, and they have undergone psychometric evaluation and been deployed in previous health service implementation evaluations. There will also be 10 open-ended questions in the survey that will be specific to medication dispensing unit location, logistics, supportive factors, barriers, and lessons learned. As far as data analysis goes, we will utilize an intention to treat methodology with a p-value of less than 0.05 to be representing statistical significance. The null hypothesis will be that baseline comparisons and 90-day values will be equal. Within patient comparisons, like the daily driving distance to obtain methadone, and the missed doses per 30 days will be analyzed with paired t-tests, and the cohort comparison of patients meeting criteria for TC30 at baseline versus at 90 days will be analyzed with a McNamar test. For AIM-2, survey results of the opioid treatment program and pharmacy staff perceptions will be analyzed with descriptive statistics, and a thematic analysis of open-ended responses using aspects of the consolidated framework for implementation research as a guide will be conducted. So while cutoff scores of the 3 arms of the survey are not available currently in the literature, for this study, we will consider scores averaging 4 or higher, indicating agreement or complete agreement on a 5-point Likert scale as indication of acceptability, appropriateness, and feasibility, respectively, of those 3 constructs of the survey. We hypothesize that daily driving distance at 90 days as part of AIM-1 will be reduced compared with baseline. We hypothesize in the proposed study that individual patient missed doses per 30-day period will decrease compared with baseline, indicating greater treatment retention as part of AIM-1. And we hypothesize that the cohort's TC30 at 90 days will increase over baseline, indicating greater treatment retention, again, as part of AIM-1. This will be our study timeline, data collection, with final analysis taking place in the last months of the study period. In summary, this project will be the first to establish a rural community pharmacy as a medication dispensing unit, and the first to assess the impact of this approach. This project seeks to create a shift in the way patients currently obtain methadone treatment, which is the gold standard for addressing opioid use disorder. As I mentioned, previous pilot studies have created a workaround or obtained special waivers or permissions rather than setting up an officially licensed medication dispensing unit, complete with a contractual agreement between the opioid treatment program and the pharmacy. So this translational research will serve as a model and hopefully pave the way for future agreements with other rural pharmacies. By creating a means to access methadone daily treatment in a rural community, we will assess the impact on patients' ability to maintain continuity with their methadone treatment. And these new ways of accessing methadone treatment have the opportunity to reduce mortality, improve quality of life, and be replicated in other rural communities. Thank you very much to the TRANSCEND team and to my collaborators for your generous support, and I look forward to working with you more. Thank you.